All right, welcome to another Slave Food Conversation. Happy Black History Month and happy Heart Health Month. I'm stepping in for our normal moderator, Jeanette Batiste, who's not able to be with us today, but I want to just go ahead and give a little bit of intro. Everyone understands about Black History Month. It really isn't Black History Month, it's History Month. And we're just emphasizing this month to discuss some of the achievements that have been obtained through those of African descent. But how many of you knew it was Heart Health Awareness Month? Heart Health Awareness Month is close to my heart as a cardiologist, so I'm very excited for today's show. We know that in February, where our nation addresses heart disease and encourages the masses into taking on a healthier lifestyle in order to prevent severe cardiovascular disease. President Joe Biden voiced his concerns on heart disease by affirming it as a leading cause of death in the United States of America. We know it has been since 1918 during the Spanish flu pandemic. The National Heart, Lung, and Blood Institute states, when we take care of our hearts as part of our self-care, we set an example for those around us to do the same. To find out more about this month and the steps to prevent heart disease, you can go to NHLBLHIN.gov or go to ABC Cardio. It also is a wonderful site for heart health information. Please continue to spread awareness about the importance of taking care of your heart. This evening, the Slave Food team, myself and Dr. Eric Walsh, we want to invite a special guest, Dr. Keith Ferdinand. He has his MDs, FACC, a Fellow of the American Heart Association, FASH, FNLA. He's degreed beyond belief. Dr. Ferdinand is a legend in the field of cardiology. He earned his BA in biology from the University of New Orleans and his medical degree at Howard University College of School of Medicine. He obtained quite a few board certifications within the medical field throughout his career. His areas of expertise include internal medicine, cardiovascular disease, the subspecialty of nuclear cardiology, and clinical hypertension. Dr. Ferdinand is a fellow investigator of the heart who passionately strives to better the health of others. Over the years, the well-respected doctor has been involved in many public health organizations, such as the Association of Black Cardiologists, where he held the title as chair and chief science officer, and the American Society of Hypertension, where he served as a board member. He currently works as professor of clinical medicine at the Tulane Heart and Vascular Institute. What a pleasure and honor it is to be with you this evening. How are you, sir?
It's my pleasure. Thank you.
It's good to see you. Good, Dr. Walsh. How are you? Good to see you.
Doing well. I'm really excited about having Dr. Ferdinand on. We know he's a wealth of knowledge, and just some of the chat we've had just before going live. I'm just excited because he's a mix. He's what I hope to be one day, a mix of a genius in history. He knows his history, and at the same time, brilliant in the field of medicine and cardiology. And there's a lot to unpack here. As African Americans, we disproportionately suffer from cardiovascular disease. So this session is going to be really important when going into this month, where not only do we remember our Black history and hope, even more importantly, to make better history going forward, but we also think about how to keep hearts healthy.
Absolutely. So we're going to change speed a little bit today. What we're going to do is we're going to allow Dr. Ferdinand to take the floor and really share with us some of his experiences, some of the things that he's seen over the course of his career. And then we're going to jump in and really have an in-depth conversation after he shares with us some of the information. So Dr. Ferdinand, please.
Thank you very much. If I can have the first slide. My presentation is going to be on Diaspora of the heart disease. I'm a native of New Orleans. In fact, I'm a child of the lower Ninth Ward in New Orleans. And I'm going to build into some of the comments that I make, the history of New Orleans in the South and how the patterns related to the slave trade affect us who are living today throughout the United States. So I called it the lessons of history. Let's have the next slide. So we'll talk about the racial and ethnic disparities. I think most of you know that. COVID-19 didn't cause them, but it unmasked them. It brings it to the forefront, what we call the social determinants of health, where people live, work, and play. have a profound effect on outcomes, including cardiovascular disease. In 1965, I lived through Hurricane Betsy. I lost my grandfather next door. And when you see pictures of people in Katrina on the roofs waiting to be saved, I actually lived through that process. And Katrina actually killed many people in the same area as my neighborhood did in Betsy. And then we'll talk about hopefully how to address some of these disparities. We want to end on a positive note. And then I look forward to being able to talk to Columbus and Eric about what we can do to overcome some of the difficulties our people have faced over the years. Next slide. So right now we're living through the pandemic, but it's not just a pandemic related to coronavirus. Social injustice and racial inequality remain on the forefront. And health disparities, which is what we're focusing on today, kind of dovetails into the social injustice and the COVID-19 inequities. Next slide. Unfortunately, this is not new. I've been practicing for decades. This is the Institute of Medicine. This is a publication from 2002. Well, you say that's a long time ago. But what they stated in 2002 remains true today. Health, life expectancy, and care have improved for all Americans, but the distributions are not equal. There's what I call a black-white death gap, where blacks have shorter life expectancy than the white population in the United States. In fact, the shortest life expectancy are African-American men. African-American women have a short life expectancy such that their life expectancy is more similar to white men than white women. And it's not driven by drive-by shootings and drugs. In fact, black youth don't use any more drugs than white youth. It's driven mainly by cardiovascular disease and poor control of what we call cardiovascular risk factors, including hypertension, diabetes, obesity, especially in black females, myocardial infarction, that's heart attacks, strokes, CKD, that's chronic kidney disease, end-stage renal disease, which is driven by poor control of blood pressure and poor control of diabetes. If you take blacks as being 13% of the population, you then compare it to people who are disabled because of end-stage renal disease, they're on dialysis and paid for by Medicare, that's about 35, 36% of the people who are on dialysis. So it's 3 times than what we predicted just looking at the population. And CV mortality, mortality means death. It comes from the Latin mors mortis, which means die. Cardio means heart, vascular means blood vessel. So the cardio part is the heart, heart attack, heart failure. The vascular part, strokes and peripheral arterial disease, is much more common in the black population, unfortunately. Next slide. Here's what I was describing. If you look at the bottom, you see the years. This has been going on for decades. The shortest life expectancy are what we call non-Hispanic black males or African Americans. Next slide. And above that, next slide, you see black females. Women tend to live somewhat longer than men, but if you look at the life expectancy of black females in the dark blue and compare it to white females, that white-black death gap has been persistent for decades. Next slide. Let me bring you back to New Orleans. It's one of the great cities of North America. It didn't enter into the United States into 1803, and we can actually thank the Haitians for that. What happened was Napoleon's army was defeated in Haiti. He was so disgusted that he wanted to give away the land that he had in the North American continent. So he sold everything in the Mississippi River Valley, at that time was called Louisiana, for pennies. That was the Louisiana Purchase. Since that time, there's been a city now that is predominantly minority, African Americans, free men of color, free women of color, African slaves, people from the Caribbean built the city. Although it was discovered by the French, similar to the Capitol and the White House, it was actually black people who built New Orleans. The guy playing the horn there is my brother, Kenneth, and he's on the cover of this major anthology that came out. New Orleans celebrated 300 years. Next slide. Next slide. Here's a picture of the so-called founder. Now, we know indigenous people were there for thousands of years, but they used the term founder when the Europeans decided to stick a flag in the mud. Jean-Baptiste d'Anville, and you can see he's standing above the indigenous person, and he's also standing above the priest as he looks over the river in the French Quarter. Next slide. We call it the Crescent City because the Mississippi River starts in Minnesota. It comes down through the Mississippi River Valley, through the Delta, where you have some of the highest rates of poverty, hypertension, diabetes, and cardiovascular disease. But when it gets to New Orleans, it turns sideways and bends and makes a crescent. So you hear the term Crescent City. The dark red area, that's the old city. The bright red arrow that I have points to my childhood home in the lower Ninth Ward. That's where the levees broke in 1965, and many people in my community died. And that same levee broke in 2005 with Hurricane Katrina. Next slide. If you come to New Orleans right now, we're going to have Mardi Gras. Unfortunately, Fat Tuesday or Mardi Gras will not be celebrated as it usually is because of the pandemic. But you see a lot of the vestiges of the African culture and the Afro-Caribbean culture in New Orleans. Not only the food, the beans and rice, the gumbo, where you put a lot of different foods into a stew, but you hear the music, the drumming, the masking. All that's part of the culture, which has been indigenous to New Orleans for centuries. Next slide. Unfortunately, it's not all fun and games. Slavery is an essential component, not only of New Orleans, but the United States. In fact, the free labor is probably what powered the United States to develop into the major industrial force that it was in the 1800s. And New Orleans could not only exist, it could not even exist without that free labor. The Europeans, again, were some of the leaders in the society. They gave names to the streets and names to the areas, but it was the enslaved people who did most of the building. Their mortality rates were high. They died digging the levees and making the drainage ditches, clearing the forest, and preparing the timber. Next slide. Here's a map of the United States from the early 1800s. And those arrows are the slave markets and how they traveled. And you note down at the bottom, at the part of the Gulf, which is the northern part of the Caribbean, that's where New Orleans was located. And it was one time one of the major, if not the biggest slave market in the United States. Next slide. What has happened, though, is that there was the Great Migration in the 30s and the 40s and post-World War II, where people left the Southeast. Some went west. A lot of people who are now in California, Los Angeles, Oakland, actually come from Louisiana and East Texas, and others went north, mainly people in the Carolinas and the northern part of the Southeast area. Next slide. Next slide. But this is the famous 1619 project. It wasn't easy. And unfortunately, slavery is built into the very fabric of New Orleans. And not only New Orleans, but the United States. And you really can't discuss New Orleans. You can't discuss the United States without talking about slavery. It's at the very center of our story. Next slide. Particularly, again, focusing on my home of New Orleans. And this is a quote directly from 1619, not my words. New Orleans became the Walmart of people selling. People selling. Queen Sugar bested King Cotton. At one time, it was the second richest state in the Union. But it also led the nation in destroying the lives of Black people in the name of economic efficiency. If you look at the sugar parishes, those are the areas around New Orleans, going to the west to Lafayette, going to the north to Baton Rouge, the deaths exceeded the births. Because the labor was free and plentiful, they were more interested in keeping the people working than they were keeping the people alive. Next slide. Here's some pictures from the 1619 project. It shows post-Civil War, the young boys working in the canes. My father came from Napoleonville, named after the same Napoleon who lost the war in Haiti. And his ancestral home was right in the cane fields. So you couldn't tell the boss, I'm not here or I'm sick, because the cane fields were no more than 10, 15, 20 feet away from where you lived. And then there's a picture here of the docks where it was the Black men who unloaded the ships to take the cane to move it around and make molasses and other products and rum, etc. in the South. Next slide. But that same sugar now has come to cause an increase in diabetes, which is high not only in African Americans, but also in Hispanic, Latinx populations. The white sugar damages not only your teeth, everybody knows about the cavities it causes, but it increases the risk for diabetes, obesity, and heart disease. It's called white gold, and it was fueled by slavery. Next slide. I have a patch on my coat. It's from Tulane University. It was called the University of New Orleans in 1851. And I'm going to show you why there is an historical distrust of Orthodox medicine among many African Americans. Older African Americans will smile, they will be very respectful, but there's a lot of distrust against doctors. And it's not because of ignorance, it's because of these types of findings. This is a major paper from 1851. A physician named Samuel Cartwright, next slide, and he described a disease called drapetomania. It was a disease of the mind that caused the slaves to run away. And Dr. Cartwright, a leading physician at that time, an erudite physician, a learned Orthodox medicine man, next slide, had a prescription for this disease. And his prescription was whipping the devil out of them as a preventive measure. And we now know that there are many other stories and side effects of the interaction between not only African slaves, but free men of color and free women of color and Orthodox medicine. Next slide. Let's talk a little cardiovascular disease. African Americans have the highest risk for cardiovascular disease among the major racial ethnic populations. Next slide. If you look at that top dotted line, you can see that the heart disease and all forms of cardiovascular disease, they're coming down. We're doing better. But I really want to bring your attention, if you look at panel D, the height of that curve, and compare it to panel E, and this is mortality. This is not social science. These are hard endpoints. This is death. Next slide. The relationship between cardiovascular disease and non-Hispanic whites, next slide, is much lower, significantly lower than mortality or death from heart disease in non-Hispanic blacks. Next slide. Next slide. Next slide. So let's revisit this map really quickly. And one of the things I'm going to show you now are data, your tax dollars are work from the CDC, in which they look at various forms of heart disease and stroke. And you're going to see, to a large extent, unfortunately, it mirrors the map of the old slave trade. Next slide. Next slide. Here's a map of people who live in poverty. Clearly high in the Southeast. You see some dark areas in the Southwest. Those would be Native American or indigenous populations. Next slide. Here's a heat map of the prevalence of hypertension, dark red being hot, and the rates of hypertension, again, higher, Southeast, Mississippi River Valley, going into Appalachia, where you have poor whites. Next slide. Next slide. Here's overall heart disease. Again, Southeast Conference is good for football, but not good for heart disease, hypertension, diabetes, and stroke. Next slide. Next slide. This is another form of a heat map, and it points right to the Gulf South, where you see the rates of hypertension in dark red and the rates of diabetes in the black patients, highest, some of the highest in the country. Next slide. So this speaks to a profound effect of the social determinants of health and history on where Black people are in terms of their cardiovascular health. Now, we've done fairly good, not as great as most Americans think, but we've done fairly good since the passage of the civil rights legislation in terms of public accommodations, access to be able to sit on the bus and in the plane and go to the hotels, and now voting rights, although we know realistically there have been some efforts to restrict access to the voting booth among Blacks. There you see the picture of Martin Luther King peering over the shoulder of Lyndon Johnson in 1965 at the time of the Voting Rights Act. Next slide. Next slide. But again, bring you back to New Orleans. Remember, this was a major center in the United States and even before the United States, because it was a part of the French Empire before it joined the United States. It was in the United States that showed that the very structure of America disadvantaged Black people and people of color for centuries. This is a Supreme Court decision called Plessy versus Ferguson in 1896. And what happened, Plessy was a free man of color, and he decided that he didn't want to sit in the colored cabin on the railroad. He wanted to go up front. And they said you couldn't. He was arrested and taken away. Well, Plessy had the means, the intelligence, and the drive to fight it through the state court, through the district court, and all the way to the Supreme Court. But to show you how structure can affect the very life of people living in the United States, the Supreme Court said that they were right to arrest Plessy and that there's something called separate but equal, and he should have stayed in the colored car, that he had no right to sit in the white car. That was an actual Supreme Court decision, Plessy versus Ferguson, that justified Jim Crow post-Civil War. Next slide. Next slide. This is a plaque. It's in New Orleans right now. It's on St. Ferdinand Street. It's not named after me, but it's a plaque that actually stands at the site of the railroad, and the railroad tracks are still there where Plessy versus Ferguson took place. Next slide. We showed Martin Luther King and the Voting Rights Act, 1965, but it wasn't easy. Next slide. It took a lot of effort in order to get access to public accommodations. Next slide. Next slide. Next slide. This is a picture. Those of you who are older may know this picture. This is an American artist who's now deceased named Norman Rockwell. He was very famous. He did covers of Look magazine. And you see the little Black girl is walking, and there's an ugly sign and a rotten tomato behind her. The men who are walking next to her are those of federal marshals. But Rockwell's famous painting was not made up out of whole cloth. It actually was a depiction of reality. Next slide. This painting was a picture of the first African-American girl to desegregate all white New Orleans elementary school in 1960. And there she is in real life with the federal marshals. Now, your next question is, why do you have to have big grown men escorting a little bitty girl to elementary school? Next slide. And the reason is, every day she went to school, she had to go through a hate line in order to enter class.
Wow.
Next slide. We all know about the Pettus Bridge in Alabama, named after a Ku Klux Klan and Confederate general and hero. Next slide. Here you see them marching. In the front is the late, great John Lewis on Bloody Sunday. Next slide. Next slide. And he was beaten, his head fractured, simply because they were trying to access the right to vote. Next slide. Next slide. This is Charity Hospital. Charity Hospital is now closed because of Katrina. It flooded, and there's a new, brand new university hospital. I'm going to show you a picture of that in a second. But if you go to New Orleans, the building is still here. In fact, I'm in my office. I'm about 100 feet from the old Charity Hospital. Many of the urban hospital, the major metropolitan medical centers, were built to serve poor Black and brown patients and poor whites. But to some extent, and I don't want to be too cynical, but I really believe that what I'm about to say is true, they got value out of that poverty, that legacy, because they saw disease, they saw uncontrolled risk factors, legs that needed to be amputated, hearts that had a heart failure, they were enlarged, and strokes, patients with cancer at various stages. So they were great teaching institutions, whether it be LA County, Cook County, Downstate, Grady, Charity Hospital, these big, massive hospitals to service the underserved. Next slide. Next slide. This is the University Hospital. I'm here at Tulane, and I usually give this lecture. There's a small statue that's outside in the back none of the students and none of the residents and most of the staff never even look at the statue. They don't even know what it is. It's a statue of Avery Alexander. Next slide. And the reason the hospital has a statue is because he gave up much of his life in order to make sure that Blacks in Louisiana had access to health care. This is a picture from October of 1963. Those of you who are young, that sounds like a long time ago, but if you do your math, that means most of the people who are African American, who are 65 and older, have a very vivid knowledge of Jim Crow and the legacy and the struggles that our people had to go through. Now, he's being dragged along the concrete by the police to be placed in the peggy wagon, was what they called the police car at that time. So your question is, what did Reverend Avery Alexander do to receive such brutal treatment? He was trying to eat in the City Hall cafeteria. Next slide. Next slide. Police brutality is not new, and extrajudicial killings. This is 1981. Again, I'm gonna keep it in the family. The guy in the front is my brother. And they took over City Hall, and you see those names that they have around their neck were people who were killed by the police. They called them the Algiers 7. Algiers is the area of New Orleans across the river. Next slide. Next slide. And the monuments, fortunately, are being taken down. In fact, it was a white mayor, Mayor Landrieu, who initiated the effort to reverse some of the historical legacies of slavery. And he took off this pedestal in the major part of uptown New Orleans, a monument to Robert E. Lee, the Confederate general. Next slide. Let's talk about natural disasters. There's a clear relationship between natural disasters and health. This is Hurricane Katrina, August 29th, 2005. It hit New Orleans, a little bit to the east of New Orleans, but the levees ruptured and people died. Next slide. That thing that's sitting in the middle of the slide, that's a big barge right in the middle of the lower Ninth Ward, my ancestral neighborhood. And you can see the waters rushing in, flooding the homes. That actually at one time was one of the largest Black communities in the United States. Next slide. Next slide. This is an actual street I lived on at one point called Flood Street. I don't know why they named it that, but that was the name of the street. Next slide. And unfortunately, similar to the long history of poor health, the social determinants where you live can affect how you are able to survive. That same area was flooded in 1965. I lost my grandfather, and for many years, I blamed myself for his death because we were sent out to try to retrieve him, and we couldn't get there because of the high winds and the water. That's 1965, the same neighborhood. Next slide. I've written a text along with an historian looking at the oral history of people who survived Katrina. After these natural disasters, next slide, there's actually an increase in heart attacks, strokes, heart failure, uncontrolled diabetes. Next slide. Because people can't seek care. Next slide. And they also have the stress of living through a pandemic. This has been published in peer-reviewed literature looking at vulnerable populations and the effect of natural disasters on health. Next slide. Chronic illnesses become worse: hypertension, diabetes, end-stage renal disease. Next slide. And along with the poor health outcomes and the death comes the police brutality. This is a little known story. This is actually a published report, Shots on the Bridge. It's about some young men who were trying to escape the floodwaters, walking across a bridge, and they were accosted, and one of them was shot dead. Next slide. There's the young man with the white t-shirt. That's his brother who's being surrounded. I said one, I should have said two. There's another person who was shot on the bridge. Many of these policemen escaped with no penalties for years, but it was during the Obama administration, approximately 15 years later, they investigated and the feds were able to bring some of these policemen to justice. Next slide. We talk about death, but let's talk about misery. This is a real picture from the Wall Street Journal. You can see the woman in the middle and her 2 children. You can feel in this poignant picture the misery that comes from the early premature cardiovascular death that our community suffers. It's a picture of Doris Washington and her 2 daughters and their feeling of utter misery after her husband, their father, died of a heart attack at the age of 49. Next slide. Here's the death rates from hypertension, non-Hispanic Blacks at the top. Look at the years across the bottom. I become somewhat impatient when some of my younger colleagues enthusiastically want to have a session or to discuss healthcare disparities like they've stumbled onto a new finding. These disparities have been unfortunately present for decades, Perhaps we're going to address them, and we'll talk about that in about 5 minutes. But let's not act like we are coming up on something that's new. Next slide. Next slide. Next slide. Some of the worst persons are persons who have no insurance, and because they get care, but they use the emergency room as their source of care. Next slide. Next slide. Next slide. End-stage renal disease, I've already told you about that. The yellow bar at the top are the rates of African Americans with end-stage renal disease, highly disproportionate. But look at the years across the bottom, nothing new. It's been like that for decades. Next slide. Next slide. Next slide. Here's a pie chart. The bigger the pie, the bigger the group. Here you can see in the light blue, the African American population. And then I carved out the population of people with end-stage renal disease. It actually is going up. As the population becomes older, as diabetes becomes more prevalent, as hypertension becomes poorer controlled, you have more end-stage renal disease. Next slide. Next slide. This is diabetes. The 2 tall bars are Blacks and Hispanics having higher rates of diabetes. Next slide. The purple bar are Asians, racial ethnic minorities having higher rates of a chronic illness directly related to diet and physical inactivity. Next slide. Here's stroke, the 2 tall bars, non-Hispanic Blacks. It's not a little bit. These are death rates, by the way. This is not, I think. These are your tax dollars at work. These are publicly available data. These are death rates by stroke, race, and ethnicity. Next slide. This is a Venn diagram I drew. I'm kind of a good artist, but I didn't do a good job with this one. But forget the art. We're basically talking about the intersection of individual biology and genotype, which has some effect on disease. But the bigger circle is the environment, the diet, the lifestyle, SES, the social economic status, and the exposures. And I don't avoid talking about race, not because I think that the genetics explains this, but the genetics is an epiphenomenon, meaning it's something on top of the social determinants. So it brings our attention to there must be something wrong in our society that allows these mortality statistics to be so prevalent for decades. Next slide. Next slide. The disparate rates are now seen in COVID-19. These are some quotes. The National Geographic called me and asked for some reflections on why African Americans were having higher rates. And I wove into it, and I don't even think that the author recognized what I was saying. I said racism is a complex gumbo-like mixture of psychosocial factors: poverty, disadvantaged socioeconomic status, suboptimal education, perceived disparities in healthcare. We all know about the syphilis study. Next slide. But it goes more than that. Next slide. Next slide. It's related to the actual socioeconomic position, the social support, the access to healthcare, and the residential environment. Next slide. That's what we call the social determinants of health. Here's some more that are listed. This is a study of 8 Americas, and it's interesting because the guy who did this study, the lead author, is Christopher Murray. That's the same Christopher Murray who now is doing the biostatistics related to COVID-19, the Institute of Health Metrics in Seattle, Washington. But this is way back, this publication was in the early 2000s. He looked at 8 Americas, saying if you take America and you cut it into little segments based on race, ethnicity, geography, next slide, then we all don't live the same. That the shortest life expectancy of Blacks in poor urban areas, and as much as a 14-year difference from the highest group to the lowest group. Next slide. Here's another way of looking at that data. When you look at the data related to life expectancy, what you actually can see is that the persons who are at the bottom have a much shorter life expectancy than those who are at the top. So that the top 1% has a life expectancy that's 14 years higher for men and about 12 years higher for women than the life expectancy at the persons at the bottom. Next slide. So here's the life expectancy difference, women versus men, the top 1% versus the low 1%. Next slide. Next slide. So what we're going to do, well, we're going to talk about this in a few minutes, eliminating disparities. Next slide. And we need to address it. Next slide. We need to make sure we have universal health insurance, access to care, identifiable sources of care, patient-centered care, reducing the implicit bias and the disparities in how we deliver care. Next slide. Treat everybody the same. At the patient level, our patients need to address their own treatment refusals and our adverse cultural habits. There are some things we can do to do better. At the healthcare systems, we need to have interpretation services for people who have English as a second language. We need to relieve some of the time pressures on physicians. I'm in my office now, and I saw, 8, 9, 10 patients in a row, and then I spent as much time treating the chart and electronic health record as I did the patients. And at the provider level, we have to be honest. All of us bring into our doctor-patient relationship, our provider-patient relationships, bias, clinical uncertainty, and even stereotypes about the behavior of our minority patients. Next slide. Next slide. Next slide. Next slide. Next slide. Here's some of the things we can work on: health insurance, medication costs. Next slide. English proficiency. And we as providers can do better. Talk to patients, use good, sensible language. Don't try to show us smart we are with all our long medical terminology. Avoid medical jargon. Use pictures and models. Use a show me technique where you ask the patient to show you back what you just told them, and encourage patients to ask questions. Patients don't really want to have an extensive, long tete-a-tete, but they do want to have their questions answered. Next slide. Next slide. This is COVID-19. Next slide. It doesn't just affect the lungs, but it can affect the heart and vasculature. Next slide. And it is disproportionate in racial ethnic minorities. Next slide. And it reminds me of Katrina. This is a publication, myself, Van Spall, and Clyde Yancey. We talked about how COVID-19 was another reflection of how people live and die. Next slide. These are some of the social determinants that affect us in the pandemic. Next slide. And here's another quote in the National Geographic. It's a mixture of many difficulties faced by African Americans which compound and extend the burden of coronavirus risk factors. Next slide. Ellis Marcellus was married to my cousin. He was my cousin, and he died with COVID-19. Next slide. Ronald Lewis was my childhood friend. I saw him on Mardi Gras, February 25th of 2020, and he subsequently developed COVID-19 and died. Next slide. The African-American mortality then unmasked the cardiovascular inequalities, the failures, and the unacceptable care that needs to be caught and mitigated. This is an editorial in Jack. Next slide. Practical steps, what we can do, that's what we're going to discuss. All right, brothers, let's talk a little bit.
Love it. Love it. Eric, I'm going to let you kind of jump in there, but I have to say, one of the things as a kid growing up, I didn't understand, and I mentioned to you kind of backstage, was the fact that my folks are from New Orleans, from Louisiana. And so I remember my grandmother distinctly. We called her Madeir, D. And I remember her talking about Charity Hospital all the time. It never struck me for one moment until I made it through med school that Charity Hospital meant that she was poor. it never once made the connection about that fact, about the humble upbringings that despite what they had, they made up for in their spirit and what they delivered and showered on their kids and invested. So I appreciate the work that you're doing in that community with your office, just a stone's throw away from that, where she had to deal with a lot of different docs and everything of that sort. So once again, thank you.
And I think for our those that are tuning in, I think we should really dig a little bit deeper into the stress connection here. I think, when we talk about stress and dangers of stress, but also the unique stressor that is racism, and it's subtle ways even. Sometimes people don't even they don't even know that what they're doing can come across as racist. Sometimes they absolutely do. There's something else you showed I really enjoyed, was the history of police brutality. When nowadays, if someone gets shot and killed by the police, there's a collective rise in cortisol and adrenaline in Black people all across the country. So let's just unpack for us a little bit about that. What was it? How stressful would it have been? So we can say that today. But how stressful would it have been to be Black in America during the 50s, 60s, even into the 70s, when a lot of this was unmitigated? And there was people could be blatantly racist if they want.
My older brother, whom I showed his name, he changed his name to Kalamu Ya Salam. He's famous in his own right. Kalamu Ya Ya Salam. He's a great poet, author. Look him up. Kalamu taught me, when I became of age and could drive a car, and at that time he was doing the sit-ins downtown, with the lunch counters, and he would get arrested and pulled away. And I'd say, I want to use your car. I got this little girl, I want to take her out. He says, look, I'm gonna let you use my car. Here's the insurance, here's the registration. You're going to get stopped by the police. And when you're stopped by the police, that is not the time to show your manhood. You don't need to die on some dark street in the back alley. Roll down your window. If they start hollering at you, don't move. If they say something out of your name, just say yes, sir, no, sir. Have your license ready. Here's the registration. Here's the insurance. And no matter what they say, don't let them egg you on. And indeed, I was stopped numerous times. I would get very anxious, but he had kind of taught me and schooled me. And I subsequently came to an understanding that the police were probably disappointed when they stopped and they saw it was this teenage boy with the car and it wasn't my brother. They probably got the license and were, trailing the car and hoping they'd come upon him in a dark alley. We know that police brutality goes all the way back to slavery, where the militia and even the Klan infiltrated or made up a large part of the police forces. In New Orleans, it has improved quite a bit, but it didn't because of just goodwill. The Obama administration did a consent decree in which the FBI was embedded in the New Orleans police after Katrina and those horrible killings on the bridge. One of the police captains actually was one of my patients, and with each police action, the FBI was there to watch and investigate, and that eventually made them stop. People don't stop just because of goodwill. You need laws, you need structure to make people do the right thing.
That's incredible. It's incredible. So, a follow-up with Eric's question is this generational racism, this generational stress we characterize as racial discriminatory stress. Speak to, if you will, really about maybe the consequence on our epigenetics, the consequence on this, on how it transforms us on a DNA level. And it may even perhaps dovetail into a reflection of, we look at how the differences in people of African descent and their blood pressure as we move from West Africa all the way into the United States, how there's a rise in the blood pressure levels that are inside the United States, which may be suggestive of, once again, there's a unique factor that's playing a role inside of things.
As you know, it's very complex. When I give this lecture, and I've given it in big halls with 200 and 300 and 400 physicians, I use mortality, death rates, and I use those timelines over decades to say that we're not making this up. This is not social science. And I use CDC data and NIH data. The mortality differences are there. But I really don't think it's that much of a mystery. If you go into the prenatal care, which is often substandard, if you go into the nutrition and the diet that the pregnant women have, higher levels of hypertension and cardiomyopathy. Cardio means heart, myo means weak heart, more heart failure. Babies are often born prematurely with low birth weight, smaller numbers of nephrons, which are the parts of the kidney, the little tubules in the kidney. So they come out to shoot. Day 0 already at risk for an increase for hypertension, chronic kidney disease, end-stage renal disease, and death. Then you build on that poor nutritional habits in childhood. Most of the food, 60% of the food in the United States comes from the US government. If you take into account the school lunch program, the military, and the penal system, all of that is procured by the US government. Some of those foods are some of the worst foods on the planet. So now if you have a population that has bathed their bodies in foods which are high in saturated fat, high in sodium, poor sources of protein, it is no wonder as they enter into adulthood, those childhood conditions start to manifest themselves as what we call risk factors. And then if those risk factors are not controlled because of health-seeking behavior, bias in the system, substandard insurance, or just bad treatment when you come into the healthcare system such that you don't really feel that great about going to the doctor and getting that 10-minute interaction with a person who really doesn't like you. We can kind of tell.
Yeah.
It is no mystery then the end stage that I showed, dialysis, renal failure, heart attacks, strokes, death, mortality. And I show the end stage, I told you, because I want to get it off the table. There's a debate. There's no debate. But it's really not, if you think about it, not surprising that that's the terminal component of a life that's been lived in struggle.
Absolutely. Absolutely. Yeah, you know, one of the other things that that you mentioned is you talked really about this history, and you brought to light some of the issues in terms of COVID-19. You brought to light some of the historical issues that led to mistrust, either from repeated implicit bias and so forth. And so let me ask you, I know you've been a leader in terms of with the COVID, on the forefront of educating folks with COVID-19 and the benefits of vaccination and screening and so forth. How do people of color overcome the fear of vaccination, right? Based on their history, based off the history that's either something that they've lived through, or like Eric said, that maybe they saw through the lives of others in the past. How do they overcome that to regain that trust?
Well, what I do is I try to look at the data. And if you look at the platforms actually have been already built. So the term warp speed was a barrier to the dissemination of the vaccines. And that came up with a presidential leadership that wanted to show how big and bad he was. But the platforms were there. And then you look at the people who actually developed the vaccine. Dr. Kismet Corbett, who worked hand in hand with Fauci at NIH. The Pfizer-BioNTech vaccine, which is a similar mRNA vaccine, was not developed by Pfizer. It was developed by a German company called BioNTech. And when you say German, don't start thinking blind eyes blues. Those were Turkish immigrants, the two leading scientists at BioNTech, and then they partnered with Pfizer to get it developed. So you had at all levels international flavors, people of color, people of different backgrounds who developed these vaccines. Then if you look at the science and you think about the Tuskegee story, the Tuskegee story was one of 412 Black men who had syphilis, and when penicillin was shown to be crucial for killing the spirocyte that causes syphilis, it was withheld. We're not talking about withholding something. We're talking about now trying to offer something. So let's think clearly. We have higher rates of hospitalization, higher rates of death, then we really need to get the vaccine. And it's not a vaccine from a previous presidential regime. These were scientists who had been working on these platforms. They actually had it for the Zika virus. All they needed was the genetic code of the coronavirus, and they could modify it and then have our bodies make the spikes so that when the coronavirus comes, we're able to identify it. One further point. I'm on the Louisiana Vaccination Action Committee, and I'm also on the Governor's Health Equity. White folks get it. You're on the West Coast. The New York Times reports that young and middle-aged whites of means are going into community centers where they would never go to get care and sitting on the ground with their laptops like they're at a concert waiting for the doors to open, so that at the end of the day, when the doses are used, they'll use it. And the same thing happens in Louisiana, and there are also published reports in New York, the same thing.
Definitely
They get it, that the vaccine could be life-saving, so they will go into neighborhoods where they would never go because they know that the Black and Latinx populations are underutilizing the very precious lots of vaccines that are available. So at the end of the day, if you don't use them, you have about 6 hours, they'll get those shots.
Yeah.
It just doesn't make sense to me that based on the science and based on the people who helped develop that science, that somehow we go for the okie doke and think that this is harmful to us. I think it's very helpful. I have been vaccinated, and I recommend to my extended family that they get vaccinated.
I've been vaccinated as well.
Same as myself. I have as well. Yeah, it's important, and so I appreciate that, because it's important. And so dispelling a lot of the misinformation out there is really kind of why, in part, we do what we are doing right now, is to kind of put people like you at the forefront and have these discussions where people can listen in to people who are studying the science, and that we look like them, we care about you, and we're hopefully resonating with some of your value systems. Yeah. No, that's true. You know, another thing that kind of popped into my mind was, you know, as you were speaking about a lot of these different variables with everyone, is when we look. Oh, sorry, 1 second. Sorry, my Siri is trying to interrupt my question, my thought process. She's referring back to me about what she doesn't have. Tell you about AI inside of all these things. So, but my question is, you know, how do we increase our value? How do we increase our value? We're highly valuable. Others' impression of our value. You know, Eric says constantly, he says, resources go where value is placed. And you've really outlined how we've been undervalued. Your neighborhood's you described growing up in an area where it's been flooded twice. The travesties that have happened repeatedly, and we're seeing around the country, and 2020 has revealed this again, and yet we still have a lack of resources on multiple fronts. What are your thoughts? How do we increase the perception of this value? How do we build upon this and finally stop having this conversation?
Young people like you and Eric, who are articulate and strong and committed, you keep doing it.
I tell you, you sent me back many years with Katrina, because I remember working at a hospital both Columbus and I worked at. I won't name it. And I remember I was the medical director for the unit I was on. And I remember one of the nurses, white nurse, very nice young lady. I'll never forget, as we were watching the news in the room where we did our charting, and she saw all the Black people in New Orleans having to walk to try and get to safety and to get help. She turned to me and said, I didn't know there were Black people in New Orleans.
Wow.
And I was like, are you kidding me? There's probably more Black people in New Orleans than anybody else. And I realized that, you know, that showed me that Americans, a lot of times, they don't even understand, they don't even know what's going on. And there were some evil comments that were made at the time about clearing the city of Blacks so that they could develop and build, you know, almost like a flash gentrification. I think it was a term I heard way back then. But it goes back to what Columbus said. Resources go where people are valued. Resources go where people are valued. And part of what has to happen, in my opinion, is there's a certain amount of value we have to place on ourselves, regardless of what else is going on around us. And I have to say, some of my relatives, I have an uncle from Americus, Georgia, and some of the things he used to teach me about the South and the community that we had, the the camaraderie, the nurturing that we gave one another, despite the external fears, threats, and so on. My worry, as we look at how we fix things going forward, is: are we losing that? Is that dismantling in America today? And what do you think about that, Dr. Ferdinand? Because I think all of that is very healthy. Community that we used to have, I don't know that I see it as much as I used to, and maybe I'm missing it. But I don't know. I see it, especially not the way my uncle explained it, coming from the segregated South.
Yeah, there's a big debate in the South. As you know, the New York Times author Bloom talks about going back. The devil, he has a whole book on going back to the South and doing reverse migration, because throughout much of the history of Louisiana and Alabama, Mississippi, Georgia, blacks were the majority. And then with the disenfranchisement and Jim Crow post slavery, the new opportunities that opened up on the West Coast for those from Louisiana, East Texas, and Chicago for Louisiana, Mississippi, and New York for the Carolinas and Virginia, that's been lost as some of those opportunities in manufacturing have started to shrink. He says, well, go back home, reclaim yourself as the dominant population with this new voting power, and control the space you occupy. It's an interesting concept. I'm home. Post-Katrina, I went to Atlanta. I was on the staff at Emory. I worked at Grady, which looks just like Big Charity. And I lived in one of those perfect Atlanta suburbs. They got a bunch of them where you have a gated community with the pool and and all of the grass is looking like it's synthetic grass. It's cut so pretty and lines. Everybody
so true.
And you drive through and you wave at the guard. And when you get to your home, you click the garage door opener, and it opens up. You drive in, you click it, and then you walk right into your home because you never have to walk outside. If you said right now that you're going to waterboard me, you're going to torture me unless I tell you the names of my neighbors in that perfect little suburb, I'd say, pour the water, brother. I didn't know anybody. So I'm back home in New Orleans. New Orleans is certainly not the richest place in terms of money and economic development, but I get so much love and comfort being in a community where people have known me for decades and all my life. And if ever I feel dumb or I feel tired or lost or confused, all I have to do is go shopping, and people say, hey, Dr. Ferdinand, they'll pick me up. They'll pick me up. So that sense of community is very important. That was a long way to get to your answer. That sense of community is very important. You can live in the richest of social construct environments and not have that connectedness that you have in other areas.
Yeah. That is such an interesting question, Eric, in response, Dr. Ferdinand, because one of the things that some of the studies and research that I kind of had looked at, it really speaks about the challenge response. And you look at the paradox in certain communities where you think, like even the Hispanic paradox, and there's others where they should have the disease burden, but somehow they have the longevity from coming together as a community. And there's a role that's there that we can't quite put our finger on as playing a response to some of the disease burden that's out there. And I think that's something that's lacking. And there's lots of theories as to why that may be inside of our communities, of this lack of community really amongst African Americans and others, and bonding together.
I am so pleased to make any small contribution to the effort that you brothers are doing. When you came to Essence 4 years ago, and as you know, that's the largest African American convocation in the world. 400,000 people over 3 days. The Superdome has 50,000 people. The convention center where you were located has 10,000s of people. I actually knew you were coming. Didn't know you, but there was a word. They got this young brother. He's talking about vegetarianism. People were there. I didn't get a chance to meet you. The point I'm trying to say is that your work speaks for itself. Eric, your work speaks for itself, and you just keep pushing, you just keep doing what you're doing. And it's gonna change. It's just a long struggle. When I was young, we used to sit around in our dorm rooms and after hours listening to Coltrane for hours. And we discussed when the revolution was gonna happen. And I remember we would say, do you think it's gonna be next year? You think we're gonna get it next year? How about, oh man, it ain't gonna take that long. I think in the next 8 to 9 months, we're going to turn this thing around. And somebody say, oh man, this is going to be a long haul. It's going to be about 5 years before we get to some equality. That is how short-sighted you are when you're young. You think that you're going to make that big change. It's a slow grind. From Plessy versus Ferguson to slavery to 2021 to COVID-19 to what we saw at the Capitol, where that brother Goodman, the policeman, in the first shots, you thought he was staring down the guy in the Q shirt and a few people. In the last shots, there were 30, 40, 50 people he was staring at. Putting his life in danger because he looked to the left, he saw the Senate chamber doors open, and he knew if that crowd had gotten there, somebody was going to get hurt. It's a long, long, long slog. The arc of justice is long, but it bends towards righteousness. And you just got to keep pushing. I'm going to be gone. You guys going to still be doing it. And then your kids or the people you have influenced are going to keep doing it. So it's not like I thought when I was in my teens and my brother was out there, you know, raising hell and getting arrested, that we're going to be there next year. Well, next year, we're going to kick this thing. It's not going to be like that. It's going to be a long, long haul. Remember, 400 years.
Yeah.
Right? Peter Tosh? Huh?
That's right.
400 years. This has been going on a long time. So don't think you're going to turn it around in 2 years, 3 years, 4 years. So Eric, to answer your question, brother, you just keep doing that. And then you're going to see some fruition, some changes, but you're not going to see it full and equal. Those statistics that I showed, those life charts were like this, flat. So I think you guys are going to be able to narrow it, but it's going to take effort.
Yeah. Man, I love it. I love it. This has been powerful. This has been extremely powerful.
Amazing.
Yes. We have appreciated you so much. Number one, giving your time after a long day in clinic. I understand that. And throwing down a different perspective on what we've been trying to really spread over the past several years. So I am so eternally grateful that you've joined us today. And this won't be the last time. I'm looking forward to when we can kind of connect in person, and maybe Eric and I can come out to New Orleans and do a little something that will be good too as well. Looking forward to it.
It's my pleasure. And yes, it is at the end of a long day, but I did it because you asked, and I did it because I know you are trying to make a difference, and I want to make a contribution. I appreciate it.
We appreciate you. Thank you.
Yes. So to the audience out there, we appreciate you all. Thank you for tuning in to another episode of Slave Food Conversations. I encourage you to like the page, share this important information. You don't get this kind of information every single day. You haven't even heard this perspective from Eric and myself. So I encourage you to share it out there with your friends and your family. And listen, stay tuned for next week. Next week, we're going to try and replicate this. It's hard to fill the shoes of Dr. Ferdinand, but we're going to plan on bringing in someone from across the pond, and Dr. Chidi, who's going to come over and talk about the disease of the diaspora across the pond in England and in Europe and many other places of people of African descent, and looking at some of the work that's being done there. And so once again, I've appreciated this show and look forward to seeing you all next week. And Dr. Ferdinand, I look forward to meeting you in person and joining into one of the conference calls on ABC and other venues.
All right. Thank you, brothers.
All right. Have a good day.
Take care.